data, concepts, sources, and applications, which we started, I think, the first week of this workshop. So we're taking the last part of this course, and that will be taken by one of our PhD scholar, Mr. Aaron Mwana. So can we give a round of applause and applause as Mr. Aaron takes us through this section. Mr. Aaron, over to you, sir.
All right, thank you very much, Mr. Oluwaseun for. Can you hear me, please?
Yes, we can hear you loud and clear.
Okay, great. Thank you very much, Mr. Oluwaseun, for the introduction. And good afternoon, everyone. I hope we are having a good time wherever we are. And I can see that, of course, it's just as if we are still on the on-site classes, because we've seen the level of response and the heart towards and the committed heart towards engaging with each of the lectures. So I really want to appreciate every one of us. So we will continue from where we stopped last time. But before I go on to continue that, it's just I would love to give a brief recap of what we did. So we started by introducing some of these concepts that we have when we talk about infectious disease data. And then we went on to talk about the types of data, talking about the primary data as well as the secondary data. And we saw that data are always from the real world. And then from the real world, we collect the data and we process and interpret it to get information. And when we get those information, then we can now start to talk about making policy out of those information which we've gotten. And then we went on to talk about the hard data and the soft data, and we saw examples of those kind of data. And then we saw particularly routine data, such as the Health Management Information System. We saw the DHS data, which is collected on routine basis. DHS IS2 data, which is collected on routine basis. And the example of that is the National Malaria Data Repository. And also we saw the map data, which we used that to answer some of questions when it comes to modeling. And then we have the Sentinel surveillance data. And then we went on to talk about the malaria threat map, which are examples of routine data. And also we went on to see data collection process, such as the KII, the FGD, that is focus group discussion. And then we collect data via direct observations and then rapid assessment. So all of those were what we did the first week. So we'll continue from there to now talk about some of these concepts, such as the surveillance, monitoring, and evaluation, which has to do with the whole of the system, which monitor and evaluate the processes and also organize and gather the use of information. And all of what it's geared towards is actually to make decisions and to manage projects, and as well as to improve the performance. And how does all of this link up? We see that the surveillance and monitoring evaluation has to do with, depending on which sector, they always facilitate the monitoring of projects when it comes to the health facility, in terms of the primary health facilities now. And how do they collect their data? Just as we've mentioned earlier, they can collect data via focus group discussion. They can also collect data via key informant interview. And then examples of such data which are collected based on each of based on the parastatals that constituted. It can be from the federal, from the state, and also from the local government. And so example of this data are such as the meteorological data, like your climate data, your weather information data, like the rainfall, the temperature, the humidity, and the rest of that. And also we have the rapid assessment data, just as the one normally when patient goes to the hospital and they have to carry out some rapid tests to diagnose if a particular health outcome is there or not. So all of these things is what is linking to the surveillance and monitoring and evaluation. And then we also have the census data, which we also talked about that day, which comes up like every 10 years. And we say that Nigeria is due for, the last one we had was 2006. Nigeria is due for one in 2016, then 2026. But of course, we've not seen all of those coming to fruition. And then we also have activity and monitoring system, which is also anchored with the surveillance and monitoring and evaluation. And we also the SME also go ahead to also do some level of verbal autopsy when it comes to checking what is the cause of death of individuals. Is it a particular disease outcome that is causing the death, or is it death due to some other causes? So surveillance and monitoring evaluation also go ahead to also do that. So we have several kinds of household surveys, which at the course of this talk, we'll also see some of them, like the DHS survey, like the MICS survey, the MIC survey, and also we also have the MIS survey. So all of these are household surveys, which surveillance and monitoring and evaluation helps us to carry out. And then, of course, Sentinels surveillance, which we also introduced the other day, and that has to do with a specific disease outcome, which sentinels had to be selected, or areas had to be mapped out for sentinels to collect data and then transmit this data through all of those transmission channels, which we have listed out from the community level down upward to the local government level, to the state, and then to the federal level, which of course always anchored by the Federal Ministry of Health, depending on the kind of disease, and also the NCDC. And the surveillance and monitoring and evaluation unit also undertake the responsibility to evaluate what is happening within the routine health system as well. All of our health facilities, what are they bringing up at every end of the month? They help to see the data and also synthesize such data. And all of this is for information to be passed across the relevant channels and to make health better for the public. And so looking at the routine health information system now, and what are their key function. Their major key function, one is to collection of data. Like we've known that data is particular key in terms of whatever we are doing, whether in terms of machine learning models or mathematical models, or even the statistics, simple statistics we are doing. Data is of utmost importance. Without data, then we may not be able to do any operational research. So the routine health information system goes along to collect this data from various primary health centers, which we have in various local governments, and they compile all of this data. And once that compilation is done, their key function again is to transmit this data down to the local government. And part of what the local government do to analyze the data and also interpret the data. So there is always a kind of loop, both the forward loop and also as the backward loop, in terms of how information flow. It can flow from down to up, and also from up to down, depending on who is collecting the data and who is bringing for those information. And so they use this data for decision making. Very important. Decision making at the end of the day will be at the forefront of every data that is collected. Data are not just, they will always remain dummy. until it is being analyzed and then being processed, and then decision is made out of them. That is the essence of collecting data. And so just like some of us that we've gone to the field, we collect data. At the end of the day, we just put those data in the shelf. Those data is not speaking to anything until it has been analyzed. And once it is analyzed, the decision are made from them. That is when we can say, yes, the data or the whole of the research process has achieved its aim. And that is why we have what we call retro information, which is very, very key. We can't hear. Yeah, for how long now?
Just about less than 1 minute. We lost.
All right. Hope I can be heard now.
Yes.
Okay, great. So I was emphasizing on the point on retro information. This is very key in terms of what we do with our data, because once we collect this data and we pass it on from the community level to the local government, to the state level, and then to the Federal Ministry of Health, the community also requires feedback from the data which we've collected from the community. They also want a kind of feedback to them. The data you've collected from us in the community, what have you done with it? What information are we getting from those data, and what life changes or what attributes are we supposed to change, or are we supposed to continue? So all of this is what is very important when we come to retro information. And I will want to ask the question just with the brief introduction I've given on retro information. So who can tell us, why does this matter? Why does retro information matter in data collection process? I don't know. If you want to speak, and just put up your hands, I think you'll be allowed to speak from our end. Mr. DP, is that possible? All right. So if you want to speak, why does this matter? Why does retro information matter? That is getting feedback after the whole data collection process from the community. You may just take 1 or 2 responses. Are we there?
If you'd like to contribute, just raise your hand. Use the React button to raise your hand, and then you'll be allowed to speak from here.
Or you can also type it on the chat box. We'll just read it out. So why do you think that retro information is essential when it comes to data collection process? That is getting feedback from the community. We have gone to the community. We've collected several health attributes from the community, and then the community is also expecting us to give feedback. So why does this matter?
Dr. Ejiro, can you unmute now?
Okay. Good afternoon, everyone.
Yeah, good afternoon.
Okay, so I feel retro information is vital because, one, you need the community to be involved in any change you're going to effect in that community going forward. Then also because they're also needed most times in community entry. And community entry is like the first step you would want to take to assess the community to even get that data that you need. So you will need to give them a feedback so that subsequently you can always get to them, and they will also be involved in participating in any change that will be required. Thank you.
Thank you very much for that wonderful response. If we are in the kindergarten, I would say that you should put, in fact, let's put our hands together for her. If we can just look at the emoji. So what she has said, very key, because at the end of the day, you're not just coming to the community once, you will still have to come again and again to get the same data. And if such a community it's not getting any feedback. It's not getting any, the purpose for which you are collecting those data. The next time you may want to come, they will not want to give that attention. They will ask you, the one you've collected the other previous time, what have you done with it? So ritual information is very key, especially when it comes to community entry, especially when it comes to, accessing the community, because some of this community, if you don't access them through the right channel, they might even be hostile to the data collectors. So it's very important that once we collect information data from the community and we process those data, it's also very important that we give a kind of community engagement with the information we've gotten from those data. Yeah, thank you very much for that wonderful response. Okay, there are some other response too in the chat box. So I will just quickly. Am I seeing?
Yes, there's a response from Ugochukwu Jane Ijeoma.
Okay, to encourage further response or access. Yes, very important. To encourage further response or access. Yes, just as we said earlier, it's very important to carry out ritual information to feed back to the community. And this will encourage further response. They will be willing to come out the next time you are coming to collect data. And in fact, they will even you will even gain some level of acceptance when it comes to the data collection. Yeah, thank you very much, Jane Ijeoma, for that wonderful response. So let's proceed. So what again is the purpose of the health information, the routine health information system? So one of the purpose that we derive from that is to provide decision makers with information for decision making. So again and again, we cannot emphasize that particular concept that it's always for decision making. We want to make decision. We want to know the way forward. We've encountered so many challenges with a particular health outcome, and we went ahead to collect data. Those data should end in decision making, should be able to guide our decision. And again, to provide stakeholders and users of the health system useful information they need. Again, it's about information which they need, and then to support planning. Of course, when data is collected, it helps us to know where are we in terms of planning. For example, the NMEP, the National Malaria Elimination Program, always engage in various strategic planning. And presently, we have the NMEP has done first and to manage the disease of interest, and again to evaluate how far have we been able to go in terms of curbing a particular health challenge, and then what services can we provide for those that are in the front line in terms of tackling these diseases. So this is very important that it's very important therefore to collect data to see what has gone before, where are we now, and what we are to expect in the nearest future. And then again, to support, of course, research for health, data collection is very important and key to that. And again, to promote international exchange of health data. So for instance, in most data we've collected, some of those funders will also they want to ask, okay, what is the current trend of this particular disease? What is happening currently? And all of these things are things that we put in many of those proposals in terms of reaching out for grants and also reaching out for support to both at institutional level, the government level, and the rest of it to access funds as the case may be. All right, so we've been introducing some of the thoughts. So we also have how does this information flow? the flow of the information, the flow of the data collection process, and how information eventually flow. I think we have introduced, but to also present this pictorially, we can see again from the community level. It's always start from the basic level. All right, from the basic level, it's always commenced from the community, and then the community from where we source this data from. We have various individuals who are always in the community to collect this data, like the CDDs, the community drug distributors. These are community health workers that go around to distribute drugs such as the Chisto drug, that is ivermectin, or drugs for STH and the rest of that, even for onchocerciasis, to ivermectin for onchocerciasis, and praziquantel for Chisto. So all of these are community workers which within the community distribute health interventions and are always in the direct contact with the community members, like also the community health extension workers, the CHU. So all of these are community individuals who work in the communities to ensure that community interventions is spread across. Also have those that you can see them even around our community carrying out various vaccination campaigns within the community to ensure that children who are eligible to get vaccine always are vaccinated, depending on the kind of vaccine. All right, so it's always from the community, and then these data are being collated, are being gathered down to the primary health centers, like the health facility within the local government. And so within this health facility, we have the front lines. The front lines within this health facility are responsible to collecting data and also collating data from the CDDs and also from the community health extension workers. And they transmit it down to the local government area, to the state, and then to the national level. And then, like we have said earlier on, the ritual information again proceeds. The ritual information again proceeds from, we can see that upward arrow going up, and then we see also the downward arrow coming down. So we have data from the community level, and we have decisions taken from the national level, trickling down to the community. All right, so the data flow process also incorporates various workers from the community. So we can see the actors, the traditional based agency, the faith-based organization, the community health extension workers, and also the community volunteers. And all of these are individuals within the community that takes up the responsibility of coming in contact with community members to ensure that particular health intervention is being given. And then we also have, of course, the public health facilities also play their role, like the primary health centers, which we have within our localities. And then also the private, very important, because if we check the endemic data, we will see that both the public sector and as well as the private sector are always reporting, yes, particular health intervention within that system. And very important for us to get all of this data in place. And when we get more of this data in place, it will actually inform a better decision. All of the actors, whether it's from the community level to the public health facilities to the private health facilities, it is very important to. Can you still hear me?
Yes, we can hear you.
Okay, I saw a kind of pop-up from my end of concerning the internet. All right, so thank you. So all of those channels must put together to get a very robust data set in order to make practical decision or an operational decision. All right. And so how do they now flow? Again, it flows into when all of these are collected from this from community and also from these health facilities. Again, they are integrated to the local government, and then data are collected in various data hubs, just like you have with your the DHIS2 data and also the SOMAS data set. All of these are collected. Of course, the DHIS data is hosted by the Federal Ministry of Health, and then the SOMAS data, which also collects data for various health intervention, is hosted by the NCDC. All right, so all of this, when we look at it, all of these are within the purview of the monitoring and evaluation process unit of various health parastatals. So we have them, the service providers from that basic level. They undertake, like I've mentioned earlier, data collection, data collation, strengthening referral and linkages, data used for planning and program improvement. And also at the local government level, what do? They carry out data quality assurance to ensure that the data which has been collated from this, from the community health provider, from the public health facilities, and as well as the private health facilities, to ensure that this data are of good quality, and they are one that we can actually trust when we use them in making, when we analyze them and use them in making informed decision. And then we also have the responsibility of the local government in terms of integrated supportive supervision, ISS. So they ensure that they undertake the role of supervising what is going on within the community, and also at various health facilities which we have domicile within that particular local government, and ensure that data is entered correctly and data is managed correctly and then disseminated upward to the state government in a correct manner, which is anchored by the state Ministry of Health. So all of these are various recording processes which can be used depending on the disease of interest. So when we go to various health facilities, of course, we have registers, and these registers contain various information which we have to fill, whether someone undergoing for an outpatient department, or individuals going for antenatal cares or immunization. All of these are information which will be collected in registers and entered. And also we have various disease outcomes as well, which will always be in that register. For example, take for instance, like malaria, when one is diagnosed, when one is recommended for a PT test, for MP test, not PT, no? Not PT, for an MP test. And of course, you go to the lab and one test, and if it comes out positive, all of these are entered within the malaria case-based form. And again, the reporting, how are they reported? They can be reported monthly. So like what we have in the NMDR, of course, it's a daily report which is being collected, but when it is being collated, it is collected as a monthly data. We also have those routine information data too, which can also be collected quarterly basis. Of course, weekly notifiable disease report form. All of these are reporting system and also time intervals which disease can be reported. Like when the COVID-19 outbreak occurred during 2020, at least for Nigeria, we saw that when we follow the NCDC platform, we saw that it was a daily reportage. It was on a daily basis that we are getting information. So that is how reporting system work, especially for the routine data. It's always come at a regular time interval. I know we've been taught time series, so it's just like a time series at a regular time interval. It can be weekly, it can be daily, it can be weekly, it can be monthly, or quarterly, as the case may be. All right, so an efficient routine health information system produces quality information, which we want to see. And that is why we have to bring all of the stakeholders, all hands must be on deck. We want to see all of the stakeholders coming into play, whether they are from the community level, whether they are at the public health facility, whether they are at the private health facility. We want to see all of them, because the more data we have, the more reliable we want that our analysis will be, and then the more better the decision we want to make will be. So an efficient routine health information system produces quality information used to improve the health system and programs taken into account. And so what are those things we want to take into account? The coverage. So we want to see, okay, the routine health system, how are they able to cover how much of the primary health facilities are reporting eventually? Like the data which we have, when we check, we see that not all of the health facilities are reporting. And so we want to ensure the routine health information system is a system that want to ensure that there is a good coverage of both the private facilities as well as the public health facilities. We want to have a very good coverage of them. We want to see that many of those health sector actually are reporting. And they want to also see the accuracy of what they are reporting. Is those facilities seeing a malaria negative patient and accounting it as positive? We want to see how accurate is our data entry. Accurate are these. Hear me now?
Yes.
All right, thank you very much. Sorry for that breaking transmission. All right, so again, we want to see how accurate those data are. And because when the data is accurate, then it can be used to make a better informed decision. And then the completeness of the data. When we see the various outlook of the data, we see various entries, which of course we need to complete. We want to see how best have those health facilities been able to collect all of those indicators, those health indicators, and they are able to complete them, completely enter all of those information appropriately in the reporting sheet, and then for good transmission. Of course, the frequency of collection must also be in place. And what mechanism do we use for the analysis? And then this analysis eventually always will lead to information dissemination. And how best can we use the routine health information system, the data we gather into this system to better inform policies, to better inform what is happening within our communities. And so the driving factors for the routine health information system, if you see and what we've been talking about the routine health information system, and of course, after this, we'll be looking at other data collection processes too. What are those that are driving or drivers or factors for routine health information system? First and foremost, we must talk about the technical aspect of it. We must be able to standardize all indicators, because if the indicators which for a particular health outcome which we want to collect or which we want to assess is not standardized, is not okay, I think I'm getting a kind of unstable internet. Can you hear me now?
Yes.
All right. So so we want to see we are talking about the driving factors now for routine health information system. And we are looking at standardizing indicators. It is very important to standardize indicators. It is not that health facilities A is using a particular indicator and health facility B is using another indicator. Then at the end of the day, when one wants to collate the data from all of those facilities, now see distorted data that you cannot really place, this one you cannot really make a good analysis of. So we must be able to standardize all indicators so that all facilities are using the same indicators. And there is no indicator that is missing in any of the form. So all of these processes are very important when we want to assess the performance of any routine health information system. So it is very important that the indicators are standardized. And then the data collection platform, there must be a platform just as we have in the case of DHIS2, is a platform for which all of this data is being, it's just like a repository for which all of this data is being deposited. So there must be a working platform. Also, we have the SOMAS platform from the NCDC. All of these are platforms that data for various health outcomes, like for that platform, and like the Lassa fever, like the cholera, the COVID-19, all are deposited in SOMAS. So it is very important that there must also always be a data collection platform for data to be imputed. Then appropriate information technology and also the skills. Of course, those collecting the data must be skillful in terms of entering the data, because once anything goes wrong with data entry, that means it's just like a chain reaction. Once one step is gotten wrong, then any other thing you may want to get from the subsequent steps is already a wrong procedure. So you cannot continue with that kind of misinformation in terms of data entry. So that is why it is very important that training and retraining of data entry, data collectors must be done on regular basis, so that these data are collected appropriately and they are entered also appropriately in those repositories or in those platforms. And then how can we also see the performance of routine health information system organization? So a system, what the structure of the health system must be that it is well structured, like we have in our own country. We can tell from the community level, we can tell also from the ward level, we can see from the local government level, we can see at the state level, and then we can see at the federal level. So these are structures of health system. And once we have this kind of structure, we utilize them very well. So it's one thing to have the structure, and on that thing that the structure is working optimally. So once the structure is in place and is working optimally, then we should to some level of certainty know that a data that will be collected from such a system is one that, of course, will be reliable and one that we can make good decision from. So also the role and responsibilities and culture of the organization. So it must be one that is transparent. It must be one that actually, of course, if we we can also get so many feedback from there in terms of how transparent our organizations are in terms of data usage and the rest of that. Of course, we know that it's a whole lot of bottlenecks when it comes to assessing data, especially for routine-based data such as those deposited in DHIS2. You will need a lot of agreements signed, a lot of MOUs before you are able to gain access to them. So, but on a more responsible scale, we should be able to have access to data and then be able to use this data to make informed decisions. But quite unfortunately, is not that so. So we also have behavioral, very important when it comes to data collectors. So for performance of routine health information system, the people in the community must be very, very much motivated, because if one is not motivated, for example, if we have hard to reach places where individuals have to go to collect this data, that's community which are hard to reach, it will now be very difficult for them to even, at the end of the day, now begin to see things like data falsification, because they will not be able to go to those hard to reach places. And eventually all they will have to do is not to sit at a particular spot and begin to, bring in one or two data. At the end of the day, when you now see such a data, it's now become very difficult to do anything with, in fact, practically impossible to do anything with such kind of data. So those people working at the community level must be rightfully motivated to be able, to carry out their responsibilities, so that if they have even hard to reach places, they will know that they can always, reach out to these places and carry out adequate data collection. And I've seen this even in those days when I work with some NGOs, that in those places, like in places where we have like the Oshun, like, in Ondo State, in Ondo State, in Idore local government, if you are aware of such kind of local government, it's full of cocoa and the rest of that. But at the end of the day, you see there's various health interventions. We are not getting to those places. Why? Because these places are hard to reach places, and the frontline health workers are not rightly motivated. And so they lack the transportation to go to those places. They are not given the right motivation at the end of the day. So they just neglect all of those places. But so when we begin to see that, motivation is very key in terms of, making individuals reach to hard to reach places. So the right thing to do now is to motivate them. And so to get a very responsible data, especially in hard to reach places, community health collectors must be rightfully motivated. It cannot be overemphasized. Motivation is very key. And of course, confidence and also sense of responsibility for those collecting the data. It's one thing to be motivated. It's another thing to also have the heart, to collecting those data. So there must be sense of responsibility in terms of Hello? All right. So I was talking about motivation and the need to motivate data collectors, and also for the need for data collectors to have this sense of responsibility, that this is actually to help the community for which they are collecting those data. Can you still hear me? I can see a pop-up message here. All right. So of course, there are strengths and also limitations to routine health information system. So what are the strengths? What do we think are the strengths? Okay, maybe I'll just continue because of our time. I'll just continue to point out those strengths. So I'm just looking at the time now, and I still have some few more slides to go. All right, so what are some of these strengths of routine health information system? Just from the name routine, you bear witness that ideally reflective of and integrated within the health system activity. So one thing that we've from all we've said about routine health information system, that this is a system you do not need to start from the scratch to start building it up again. It's already a system that has been integrated within the health framework. And so the health experts in the various health facilities, whether public, private, or within the community, are already responsible in collecting those data. So you do not need to build a special framework to start collecting a routine health information system data. All we need is to motivate these individuals. They are there already, and then for them to continuously collect those data. So routine health information data also is continuously collected and also suitable for frequent reporting. So like the data we use for our malaria center, it is an NMDR data we collect. Hello, can you hear me? Hello. All right, so I was citing an example with the data which we use here in our center for modeling. And so that it is a routine system which collects those. Huh? Network. Hello, can you hear me? Hello? Okay, so thank you. I'm sorry for the glitches. All right, so within health system, like I've emphasized, they are continuously collected. So of course, we've made mention that the systems are readily available. So we have the primary health system, we have the secondary health system, we have the tertiary health system, we have the community extension workers. All of these are individuals that have been in place in collecting data. So the system are already in place and they're already reporting. So all we need to do is to motivate individuals to continuously to report and to motivate facilities to always or to also engage in terms of reporting, so we can have a more robust data within our routine health information system. And so what are some of these limitations to routine health information system? We can see that data is limited to health service users. So for one to gain access to this data, to use them, for example, for what we do, like the modeling work or for machine learning models, we see that you require a lot of there is a lot of bottleneck that one will have to overcome. And so the data is not readily accessible. You need to meet various stakeholders, you need to engage with them. They need to see what you are doing. They need to be sure that what you are doing can actually help in in making decisions within the health framework before those data can be released. We know what the director here at ICAMDA had to go through before we are able to even access the data we are using here today. So data access is a very huge bottleneck when it comes to routine health information system. It is always just available within the service providers. And one thing with the service provider, all they will do with that, with what they have, is just surface analysis. When we check the DHIS2 platform, all that is there is just surface analysis. But to get in-depth analysis, like the time series models we've been introduced to actually see trends, the patterns, when to give out certain interventions, and all of those things, and what even quantity, the measure of the quantity of such intervention when it comes to mathematical modeling, quantifying those things, you see that you need more than just a surface level analysis. And with that, you need to engage with those stakeholders to be able to gain access to such kind of data. So data access is a very great limitation when it comes to routine health information system. So it's also difficult to determine the population at risk. So when you look at what is obtainable within the routine health information system, these are individuals. For example, in health facilities, there are individuals that are perhaps within them, they are showing some level of signs, some level of symptoms. So they visit hospitals and they are diagnosed, perhaps take for instance malaria, they are diagnosed of malaria, and with that they are able to the health providers are now able to report, oh, this so and so person are diagnosed of malaria, so we have MP positive, and the next day they are expecting individuals to come to the health facilities again and for them to make recordings. So it is very difficult to actually determine the population at risk, because for a situation like malaria, for disease like malaria, we've been told that even the asymptomatic population contributes much of to the disease burden. And so, and the asymptomatic individuals, they're not coming to the health facilities, they are there in the communities, mixing with everybody, and the mosquitoes take the parasites from them and inject to other individual without the parasites. So you see that for a routine health information system, it may be difficult to actually determine the population that is at risk, because it did not take account of everyone. It's just individuals that are coming to the health facilities that the routine health information system is able to account for. So again, we are faced with the challenge of quality and the completeness of the reporting. And then you will see that it varies. Not all facilities are reporting, all right? And again, and also, okay, so not all the health facilities are reporting, and even for the health facilities that are reporting, some of them are not, including all of the indicators that there is for it to include. So all of this also serve as a bottleneck when it comes to routine health information system. And so other limitations are, of course, there are also potential for double counting, both within and also between health facilities. And again, also stressing on the point of motivation. Motivation is always a key. So sometimes some of these health facilities are poorly motivated, are poorly funded. And with that, they lack the motivation, to bring to bear all of this. So I'll be ending with what is the purpose, because my time is up, but I'll be ending with, on this note, the purpose of routine health information system. What are the purpose? We can see that it strengthens subnational level surveillance and response for priority diseases. So we can see that priority diseases within the health information system, like the one that is captured within the DHIS2, of course, which we have the NMDR data, the malaria data, it captures, priority diseases. Also, the one we have in the SOMAS data, that the Surveillance Outbreak Response Management and Analysis System, it also captures priority diseases such as Lassa fever, cholera, COVID-19, and other infectious diseases. So we may, if on our own, we can gain access to some of the data like the one in DHIS2 and the data in SOMAS, it will actually help modeling framework when it comes to whether it's on mathematical modeling or machine learning models. So the performance for routine health system as well, it shares resources among disease control programs, also translate laboratory data into specific and timely public health actions. Again, we cannot overemphasize on the need for decision making once we come after the data collection, we now want to make decision. It provides timely, complete, and regular high-quality data. It's on a regular basis, with just like the name implies, routine. It's on a regular basis, and we've seen those regular intervals that it could be daily, it could be weekly, it could be monthly, it could be quarterly, as the case may be. And it can help us to dictate and predict epidemics. So, such as the early warning system, just as we have, the SOMAS data actually. And the SOMAS platform was actually implemented, I think during 2014, during the Ebola outbreak in Nigeria. So that was when the SOMAS was instituted, and it helped in early warning system. And again, we see that being utilized during the COVID-19 period. It also helped us to have early warning system across various subnational and the nation as a whole. So it allows efficient monitoring and objective assessment of intervention programs. So we've carried out interventions. We are collecting data on routine basis on how much the intervention we've put in place is able to mitigate the disease, or the particular disease of interest, and how best we can also optimize the use of various intervention, to mitigate the various diseases of interest in our various health systems. So routine health system help us to see that efficient monitoring and objective assessment of intervention programs. So on this note, I will want to end this class because my time is fast spent, and so to entertain questions if we have any questions. Thank you.
Thank you very much, Mr. Aaron. A round of applause for him. Can we clap, Mr. Aaron? Thank you very much for taking us through the importance of RHIS, routine health information system, data, the importance of data, and that the more data we have, the better our research. And Mr. Aaron also mentioned that if we do not have good or quality data, we cannot do operational research. Our research will be limited, and only until we have good data, we can be able to do research that will be able to inform policy. So are there questions for Mr. Aaron? Questions? Can you hear me? Yes. So, question. Okay. Right, thank you. So, are there any questions for Mr. Aaron? Okay. Muslima, let me see if I can unmute you. Okay. So, Muslima, can you unmute now and ask your question? Are you there? Hello, Muslima. Yes, I've asked her to unmute. Okay, all right. So, Mr. Aaron, let me just ask this quickly before any other person come on. You mentioned something about indicators. I don't know, what do you mean by indicators earlier? You talked about different indicators or so. So what do you mean by that? Can you explain more on that?
All right. So yeah, so we talked about and standardizing all of those indicators when it comes to routine health information system. Of course, we have reports and files for which all of the particular indicator of interest needs to be collected. So when we talk about indicators, we are talking about just on the basic level now, is the person coming in to be tested, is she a female or male? You record that's the sex indicator. Is the person positive or negative after diagnosis test? You indicate this person is positive, this person is negative. If, for example, where we do MP count, to what level is it 2+? Is it just a plus? Or all of these things are indicators for a particular health outcome. So indicators are just more like the questionnaire which is to fill for in terms of collecting a disease, a particular disease interest or particular disease health outcome. So all of those indicators, and this must always be standardized. All right, it must be standardized within all of the health sector. It must be the same for all of the health sector. It's not when one health sector is for example, collecting an indicator which has to do with level of anemia in individual, while this other person is just doing only level of parasitemia and the rest of, before you know, everything will be conflicting. So the indicators, the health indicator for a particular disease must be the same across all board. And with that, we should be able to now use it to appropriately, answer, pull together all of those data sets and then appropriately answer a particular question of interest.
All right, sir. Thank you very much. So there's a question from Great Media Enterprise. So please, if you have questions, you can drop them on the chat box, or you indicate by raising your hand so that we can allow you to speak from here. So the question says, how does this RHIS integrate with national or regional health databases, e.g. DHIS2? Did you get that, Mr. Aaron?
Yes, I got that clearly.
All right.
So yeah, thank you very much for the question. So again, I will again reiterate the routine health information system. Like I said, these are systems already in place. And if you will recall, part of what I talked about is that for every routine health system, for it to be a very, very efficient and for us to be able to track the performance, it must have databases for which data is being reposited to, or which as data are being collected, are being taken. But I'm connected to Starlink. No. You can hear me, right? All right. So I was responding to the question by Great Media Enterprise. Okay. So like I've said earlier, if you listen to what I've said here, that the routine health information system is a system that collects routine data. All right. And for it to be, for us to assess its performance and for it to be very effective, it must have a platform, a repository where each of those data will be deposited. And for the RHIS, The platform is the DHIS2. Hello? All right, so like I was saying, depending on the kind of data, depending on the kind of health outcome, and also depending on the body which is hosting that or which the responsibility for them is to see to that disease, either the Federal Ministry of Health or the NCDC. Like the DHIS2 is majorly domiciled within the Federal Ministry of Health, and all routine information system coming in from various health facilities at the community level, at the local government level, the state Ministry of Health, is always deposited on the DHIS2. All right. Then, well, other data repository like the SOMAS data, which is hosted by the NCDC. So data like Lassa fever, cholera cases are deposited on that database. So the routine health information system is just a system that collects data within various agencies, from the community to the federal government, and the database is the DHIS2. It's the integrating database for all of those data sources.
All right. Thank you very much, sir, for your time and for the response. Are there any other questions? Any more questions for Mr. Aaron? Okay, so in the absence of other questions, we've come to the end of this session.